Alright, so in our last lecture, we pretty much laid out all the parts of our digital imaging toolkit. Today, we're going to learn how to actually use it. We're stepping right up to the control panel to master all the things a radiographer can change. You know, the knobs, the dials, the positioning, everything that turns a basic X-ray into a really, truly diagnostic image.
This quote right here, it's perfect. It's the theme for our entire discussion. We've spent time learning the language of physics. Now we're diving headfirst into technique, the practical hands-on choices that actually create the image we're going to look at.
Yep, that's the plan. We've got all the pieces, the detectors, we understand pixels, the core physics. Now it's time to put it all into practice. We're going to walk through every single controllable factor, from the electrical settings to how you position the patient, and see how each one impacts that delicate balance between fantastic image quality and patient safety.
Okay, let's start with the two most fundamental controls on any X-ray machine. These are the big ones. They determine the quality and the quantity of the X-ray beam itself. This is really the heart and soul of radiographic technique.
Kilovoltage, or kV, is what we call the master control. And you can see why right here. You touch this dial, and you don't just change one thing, you change, well, basically everything. You crank up the kV, sure, you get better penetration, and you actually lower the patient dose. But, and it's a big but, you get lower contrast and way more scatter. It's a constant balancing act.
So why? Why does higher kV kill your contrast? Well, it all comes down to this fundamental battle happening inside the patient. At lower energies, the photoelectric effect is king. It's super dependent on the atomic number of the tissue, and that's what gives us that beautiful, sharp, high contrast between bone and soft tissue. But as you turn up the kV, Compton scatter starts to dominate. And Compton scatter, it doesn't care about atomic number. It just creates this low-level fog all over your image, washing out the detail. Now pay attention here, because this is a classic exam trap. It just feels wrong, doesn't it? More power equals less contrast? But the physics doesn't lie. Examiners absolutely love to ask this because it shows you understand why things happen, not just what happens. Higher energy favors Compton, and Compton is the mortal enemy of contrast. Simple as that. And this table just brilliantly shows how we use that knowledge in the clinic every single day. Look at mammography. We need to see tiny, subtle differences in soft tissue, so we slam the kV way down to maximize that photoelectric effect. But then look at a chest X-ray. We have to blast through the dense spine and heart, so we use a really high kV to get the penetration we need, and we just have to accept that we're going to have lower contrast. So here's the crucial point to lock in. If kV is the master control, this complicated knob affecting both the energy and the number of photons, MAS is way, way simpler. It's purely a quantity control. You double the MAS, you simply double the number of photons coming out. That's it. Their energy doesn't change one bit. Let's really hammer this home, because this is probably the other biggest exam trap out there. Someone will say increasing MAs improves contrast, and it is absolutely false. The actual difference between the tissues, that's set by your kV. What MAs does is it cuts down on the noise. By just flooding the detector with more photons, you get a much smoother, cleaner image, which makes the contrast that was already there way easier to see. Now, I want you to remember this number. Just burn it into your brain. It's one of the most useful clinical rules of thumb in all of radiography. 15%. And here's why that number is so powerful. The 15% rule is your secret weapon for lowering patient dose. You can increase your kV by just 15%, and then you get to cut your MAS in half, and you'll get roughly the same exposure to the detector. You've just slashed the patient's dose. Now, of course, there's no free lunch. The trade-off is you've also lowered your contrast by increasing the kV.
Okay, so we've set our beam's quality and quantity. Now let's talk about geometry. The physical setup of the tube, the patient, and the detector is every bit as important, and it has direct control over things like sharpness and distortion.
The inverse square law isn't just some abstract concept from a textbook. This is something radiographers calculate all the time. As you back the tube up, that beam spreads out, and the intensity just plummets. This slide shows a perfect real-world example. To go from a standard 100 centimeter distance to a 180 centimeter distance for a chest X-ray, you have to more than triple your MAS just to get the same exposure. And it's not just about distance. These three principles are absolutely key to getting a sharp image. First, you have to minimize that object-to-image distance, or OID.
Get the patient as close to the detector as possible to reduce magnification. Second, choose your focal spot wisely. The small one for fine detail, the big one when you need to use a high MAS. And third, you can use a clever little physics trick called the heel effect. The beam is actually a bit more intense on one side, the cathode side. So we can put that side over thicker anatomy, like the belly in a lumbar spine X-ray, to get a much more even exposure.
So, we've set our exposure, we've nailed our geometry. But the beam coming out of the tube isn't perfectly clean, and once it hits the patient, it creates a total mess of scattered radiation. So our next job is to clean all that up.
Here's another number for you. This one's an absolute, non-negotiable regulatory requirement. Every single X-ray tube has to have at least this much filtration.
And the reason for this is purely about patient safety. Think of filtration like a bouncer at a club. It's there to stop the weak, low-energy X-rays. Those are the ones that would just get soaked up by the patient's skin, adding to their dose, but they were never strong enough to make it through to the detector anyway. Filtration hardens the beam, making it safer and more efficient. Okay, to fight that contrast-killing fog from scatter, we've got this whole toolkit. Grids, air gaps, compression. They're all great, but I want you to look at that first bullet point. Collimation. Simply tightening your beam to only the area you need to see is the single most effective thing you can do, period, to reduce both scatter and patient dose. Always, always start with tight collimation. Okay, let's put it all together. This is that aha moment where everything we've been talking about just clicks. This next slide, this is the ultimate cheat sheet. It connects every single one of these factors to its specific effect on image quality and dose. This matrix is basically your guide to the trade-offs that define radiography. Let's just follow a couple of these. Look at the KV row. You increase it, your contrast goes down and your dose goes down. That's a classic trade-off. Now look at adding a grid. It makes your contrast way better, which is awesome. But to get enough signal through that grid, you have to crank up your technique, which means the patient dose goes up. You see, every single choice has a consequence. So with this whole matrix in our head and this understanding of the physics, how do we actually make a decision when there's a patient on the table? Well, the answer is that there is no single right technique. The right technique depends entirely on the clinical question we're trying to answer with that specific image. Instead of one technique, we can optimize for different goals. If we're hunting for a really subtle fracture, we're going to run a maximum contrast protocol with a low KV. If we're imaging a child, our top priority is a minimum dose protocol, so we use a high KV. And for superfine bone detail, we switch to a maximum sharpness protocol. Now these can be set manually, or you can use tools like automatic exposure control, or AEC. But a quick warning on that. With AEC, you have to pick the right sensors. If you pick the center chamber for a chest X-ray, you'll get a perfect picture of the spine, and the lungs will be completely white and useless. And that really brings us to the most important point. A perfect radiograph is never, ever an accident. It is the visible result of a whole series of deliberate, physics-informed choices. It really is a decision tree, and understanding all these factors is what lets us navigate that tree to get the right diagnosis at the right dose every single time.